Good morning, everybody. Welcome to Global Neurosciences Institute Grand Rounds. Our Grand Round series is a CME granting activity, and you should use each system in order to claim your CME certificates. And now it is my great pleasure to introduce our speaker, Dr. Parneet Grewal. Dr. Grewal completed her neurology residency at the University of Kentucky in Lexington and her vascular neurology fellowship at Rush University Medical Center in Chicago. She is currently working as an assistant professor at the Medical University of South Carolina in Charleston. Her areas of interest include treatment of acute stroke, along with improving systems at care for acute stroke, stroke in young, and stroke rehabilitation. She is also passionate about resident wellness and education, and educating the community about stroke. Dr. Grewal will be speaking today about cerebrovascular complications and protean disorders of immunity. Dr. Grewal.
Yeah. Good morning, everybody. Thank you for having me. As Peter said, I'm an assistant professor in the Division of Stroke Neurology at Medical University of South Carolina. And today we're going to be talking about the cerebrovascular complications in protean disorders of immunity. This ties in very closely with my research and the clinical interest of stroke in young. Without further ado, I do not have any disclosures. So let's start with a little bit of Greek mythology. Yes. Okay. Proteus actually was a minor sea god in ancient Greek mythology. As a superhuman deity, Proteus had the ability to change his appearance at will. In Homer's Odyssey, Proteus is confronted by Menelaus, a king of Sparta and the cuckolded husband of Helen of Troy. Struggling to break free from Menelaus, Proteus actually changes his shape and becomes first a lion, then a serpent, a pig, and a tree. Unable to escape, he is forced to tell the warrior king of the impending death of his beloved brother, King Agamemnon of Mycenae, who would be murdered by his own wife and her scheming lover upon returning from the sack of Troy in 1200 BC. From this feature of Proteus actually comes the adjective protean, which means versatile, mutable, or capable of assuming many forms, which is how a lot of us see autoimmune disorders. The objectives of today's talk would be to discuss systemic autoimmune diseases and cerebrovascular system, to discuss neuropsychiatric complications seen in lupus spectrum disorders, and to discuss the role of rheumatoid arthritis in stroke. So autoimmune disorders, they are a heterogeneous group of disorders characterized pathophysiologically by immune dysregulation. They can affect many organ systems, including central nervous system. Stroke is a common complication along with other complications that can involve both CNS and PNS, and prompt recognition and initiation of treatment is needed for good outcomes. A lot of times, CNS complications can be the presenting symptoms of autoimmune disorders. The work on neuromanifestations of autoimmune disorders, as far as I could find, dates actually back to 1872 at earliest, when the first report of stupor and coma in a patient with SLE was published by Hebra and Kaposi. In 1900, serology as a predecessor of modern immunology had already taken shape together with the sister science of bacteriology. The most concise paper on CNS in lupus, if you actually Google, there's a lot of publications, but the first most concise paper was written in 1945 by Dr. Daly. And it was in 1947 that Brust found a high incidence of rheumatic obliterating arteritis of CNS during his postmortem studies on psychotic patients with rheumatic heart disease. So it's not on patients with neurological issues, but on psychotic patients. In 1948 is when Bauer and his co-workers, they detected CSF abnormalities in patients with rheumatoid arthritis. And in 1963 is when one of the most well-known and concise book on autoimmune diseases was published. The figure here shows the dust cover of the autoimmune diseases book in 1963. And in the picture, they actually also included the autoimmune New Zealand black mice that were one of the prompts for writing the book. In 1979 is when the first system for classification of neuropsychiatric SLE was proposed, but in 1999 is when a detailed description of 19 NPSLE syndromes was written up by a committee that was assigned by American College of Rheumatology. And this description from 1999 is still the most concise one. And in a lot of papers and book chapters, this is the descriptions and the table that you will find. So going on to talk about what are some of the autoimmune and or inflammatory diseases that can be associated with secondary cerebrovascular complications. So this is an area where we work very closely with our rheumatology colleagues. So some of the diseases are systemic lupus erythematosus or SLE, antiphospholipid antibody syndrome, Sjogren's disease, rheumatoid arthritis, scleroderma, and then there are some systemic inflammatory diseases also that can have CNS complications, such as Behçet's disease, giant cell arteritis, Takayasu's arteritis, polyarteritis nodosa, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, and cryoglobulinemia. So patients with all of these diseases can have stroke and other cerebrovascular manifestations. This slide actually shows the prevalence of autoimmune diseases in US. I have highlighted some of the more prevalent and more common ones. So you have Sjogren's syndrome, which affects about 0.4 to 3.1 million US adults. You have rheumatoid arthritis, which is 1.3 million US adults. SLE is 161K to 322K US adults. Systemic sclerosis is 49,000 US adults. So from this table, you can see that these diseases are very prevalent in our population. And it is this prevalence that makes it very important to recognize even the very rare manifestations, including those involving CNS, which is what, as neurologists, we would encounter. So we're going to talk a little bit about a case that I saw that pertains to this talk. So we had a 22-year-old woman who presented to the hospital with abrupt onset of partial complex seizures. She was diagnosed with SLE about 5 years ago. Her ANA and anti-dsDNA titers were elevated after she was admitted at that time for unintentional weight loss and anemia. A year later, she was diagnosed with lupus nephritis by renal biopsy. And then 2 years later, so about 3 years before she came for this admission, she was actually diagnosed with epilepsy after several occurrences of rhythmic jerking. EEG did not show any epileptiform discharges. Her CSF analysis was unrevealing. MRI brain just showed like a venous anomaly. And MR angiography at that time did show some irregularities, but it was considered that they represented an artifact. So she was started on prednisone, hydroxychloroquine, and immunosuppressive agents, initially azathioprine, and then switched to mycophenolate, along with levetiracetam 750 milligram twice a day. 8 months before her current admission, she actually stopped her immunosuppressive therapy for 2 months as she attempted to become pregnant. It was then restarted a couple of weeks before when she actually experienced a flare-up of her lupus. This was her examination. So her general examination, it showed a slightly elevated heart rate. And her neurological examination, I've highlighted the pertinent positive, but she basically aroused to painful stimuli, would only grunt and make incomprehensible sounds. She had left gaze deviation, would withdraw to pain equally in all extremities. We were not able to assess anything else. This was her CT scan that was done in the emergency department, which was essentially unrevealing. She was admitted to the hospital. She was given levetiracetam load. Stat EEG was negative, actually, for status epilepticus. She was admitted electively intubated. And then she had sepsis workup performed, including lumbar puncture, and was started on antibiotics. Her immunosuppressive agents were actually held due to concerns that this might be an infection. She underwent MRI head and then CTA head and neck. So jumping here, these were her laboratory studies that we got on day 1. So her ANA titer was positive. Her anti-DNA titer was 1:80. She had reduced C3 and C4. Anticardiolipin and lupus anticoagulants were negative. Her anti-MPO antibody was increased, and so was her anti-serine protease 3 antibodies. This was her first spinal fluid analysis that we got on day 2, along with the MRI scan of her brain. So as you can see on the spinal fluid analysis, we only could get a small sample, but we found out that protein was elevated and her infectious workup was essentially negative. There were no malignant cells. Cytospin only revealed rare mononuclear cells. The MRI here shows an area of cortical ribbing on the right in the DWI scan, along with some contrast enhancement on that side in the leptomeningeal area. We also, so after that, since the sepsis workup was unrevealing, on day 3, we actually consulted rheumatology. And it had the first lumbar puncture. They recommended a repeat lumbar puncture. They recommended CTA, cerebral angiogram, and then she was restarted on her home immunosuppressive regimen along with IV methylprednisolone. So this was her CTA that was gotten on day 3. So as you can see in the figure A and B, especially looking at the anterior cerebral artery, there are areas that look irregular in the ACA territory, especially you can see in figure B. And that prompted us to actually repeat the second spinal fluid analysis and also get a cerebral angiogram. In the second spinal fluid analysis, her protein was again elevated at 117. But we sent additional studies, and she also had elevated CSF IgG, CSF IgG synthesis rate, CSF albumin index was 35, which was concerning for severe impairment of blood-brain barrier, no oligoclonal bands, and her CSF amino acids were normal except for serine and tyrosine. So the figure here shows her. The figure here kind of shows her, it's a cerebral angiogram. This is the left ICA injection with oblique rotation. The arrow points to her anterior cerebral artery, and you can see how it shows a classic pattern that is concerning for vasculopathy with beading appearance. After this, we started her back on her immunosuppressive regimen along with high-dose steroids. Transthoracic echocardiogram was performed on day 6, which revealed hyperdynamic circulation and moderately sized pericardial effusion. She was, after consulting with rheumatology, she was actually also started on IV pulse administration of cyclophosphamide. After consultation with gynecological service to optimize ovarian protection, cardiology service was consulted for management of pericardial effusion. We repeated a TTE on day 9, which revealed that the effusion was slightly smaller. And on day 10, she was discharged home on cyclophosphamide, prednisone, hydroxychloroquine, increased dose of levetiracetam, with neurology, rheumatology, nephrology, cardiology, and gynecology follow-up. So I wanted to highlight this case to show how with this disease, a patient so young can have so many systems affected and have so many different presentations and need such a huge multidisciplinary care. So this case presented the complicated course that can be experienced by patients with lupus, and that is why, you know, it's very important as neurologists to be involved in the care of these patients, both inpatient and outpatient, for long-term follow-up, especially patients who have CNS manifestations, and take care of them after they are discharged from the hospital. So what is SLE? We briefly touched that it is an autoimmune disorder. It is actually a multi-system autoimmune disease with varied clinical manifestations and outcomes. Autoimmune, it is characterized by B lymphocyte activation with synthesis and release of antibodies targeting autoantigen in multiple organs. It can have alternating periods of flare and remission. The prevalence is about 45 out of 100,000 patients worldwide, and up to 90% of cases occur in women of childbearing age. The Protean presentations of lupus confound accurate early diagnosis. Vascular lesions are an important mechanism of tissue damage in multiple systems, and the incidence of vasculopathy actually ranges from 10 to 40%. The most common is the involvement of skin or having cutaneous lesions, which is what is shown in this diagram. So they occur in about 85% of patients and are first sign in about 28%. Neuropsychiatric involvement in SLE, the incidence varies from about 20 to 60% depending on the inclusion criteria that is used in various studies. Vast majority of them actually involve CNS rather than PNS. This slide actually shows the clinical and immunologic criteria for SLE diagnosis classified according to the Systemic Lupus International Collaborating Clinics criteria. I apologize for the busy slide, but it basically shows that there is clinical criteria and then there is immunologic criteria. You have cutaneous lupus, you have oral ulcers, you have alopecia, synovitis, serositis, renal manifestations, and then neurological manifestations and hematological manifestations in the clinical criteria. The neurological manifestations include seizures, psychosis, mononeuritis multiplex, myelitis, peripheral or cranial neuropathy, and acute confusional state in absence of other causes, including toxic metabolic uremia or drugs. And then the immunological criteria include checking ANA level, dsDNA level, various antibody, low complement, and direct Coombs test in absence of hemolytic anemia. So when you do lab studies in patients with SLE, you'll see that anti-nuclear antibodies are present in almost all of the patients, but they're also present in 7 to 10% of general population. So they can occasionally be positive in patients who do not have lupus. Anti-dsDNA antibody is present in approximately 70%, and when present are diagnostic of the disease. Efforts to identify one or more triggering antigens have actually shown that anti-DNA antibodies often cross-react with bacterial antigen. So it's thought that they actually arise by failure to regulate B cells that acquire autoreactivity by somatic mutation during response to microbial antigen. You can have elevated CSF, IgG, IgM, or IgA, and blood-brain barrier is present in about 30% of SLE patients. This is the classification from 1999, developed by an international multidisciplinary committee that included rheumatology, neurology, psychiatry, and hematology. You have CNS and PNS complications. CNS complications include aseptic meningitis, cerebrovascular disease, demyelinating syndrome, headache, movement disorders, myelopathy, seizure disorders, acute confusional state, anxiety, cognitive dysfunction, mood disorder, and psychosis. Headache and mood disorders, including depression, are the most frequently reported manifestation. Psychosis can present in about 1.5% of lupus patients, although its frequency has varied among various published literature. Focal and generalized seizures have been reported, and their frequency is about 4.6%. They usually occur actually early in the disease course and are associated with higher disease activity, a history of psychosis, antiphospholipid, or Smith antibody. So what is the model for lupus brain disease? There are several proposed mechanisms as to why patients have neuropsychiatric SLE and why they have various manifestations. Many studies have actually identified renal antigen that can be bound by anti-DNA antibodies, including laminin, heparin, or actinin. They show that these anti-DNA antibodies not only cross-react with microbial antigen, but they also cross-react with non-nucleic self-antigen, displaying cross-reactivity. The other thought is immune complexes. They appear to be involved in all solid organ inflammation in SLE. Immune complexes containing either DNA or RNA are particularly pathogenic, and they actually initiate an inflammatory cascade in multiple cell types and enhance antigen presentation, leading to both systemic inflammation and accelerated atherosclerosis that is seen in these patients. Antibodies can also interact with platelets or clotting factors, contributing to local brain ischemia. Some microinfarcts may also be secondary to non-deformability or red blood cells, because these red blood cells are coated with immune complexes. Human antibodies derived from serum of SLE patients and isolated on a peptide affinity, they actually caused neuronal cell death when they were injected into a mouse hippocampus. These are the anti-DNA, anti-NMDAR antibodies. They do not cause tissue injury in brain through immune complex formation. No, it is thought that it is actually the tissue death is actually through direct activation of cell signaling pathway. So these antibodies, they bind with the NMDA receptors, and then they can actually cause cell death in both hippocampus and amygdala, which actually explains as to why patients with neuropsychiatric lupus have memory impairment and mood disorders. These antibodies can affect fetal brain development if they're passed from a mom to a baby. Going back, another hypothesis that is most widely thought to explain neuropsychiatric SLE, it's known as two-hit hypothesis. So basically, this model actually elucidates the two-hit hypothesis in SLE patients. The first is that the first is neurotoxic antibodies, and the second is an insult to blood-brain barrier integrity. The compromise to the brain integrity is actually not mediated by the disease itself, but by a disease-independent insult, such as infection or stress in patients with SLE, which damages the blood-brain barrier, giving antibodies access to the brain, and then the B lymphocyte synthesis, and there's release of neurotoxic antibody with binding affinity for NMDA receptors in the neurons. So talking a little bit about, so we talked about what was the model, talking a little bit about pathology in SLE patients. SLE patients, in various autopsy studies and literature, they have revealed a wide array of neuropathological findings, including multifocal microinfarcts, macroinfarcts, vasculopathy, microthrombi, hemorrhage, ischemia, demyelination, and rarely vasculitis. Integrity of the blood-brain barrier, it plays actually an important role in SLE-related neuropathology in trapping the immunoglobulins and complements. Pro-inflammatory cytokines and autoantibodies upregulate the expression of adhesion proteins on surface of vascular endothelial cells, which actually facilitate entry of lymphocytes into the CNS. The most common neuropathological finding is microvasculopathy, which affects arterioles and capillaries. It is believed to arise due to deposition of immune complexes and activation of complement cascade. True CNS vasculitis is very rare, accounting up to 10%, but in some studies, the percentage is only 1% in postmortem studies. The figure here shows microscopic and immunofluorescence finding in patients. So if we go on to figure A, you have histologically microinfarcts. They were characterized by neuropil pallor in white matter or gray-white junction with surrounding microglial proliferation. And the myelin loss is actually better highlighted in the figure 2C. And then the microthrombi actually identified in the periphery of microinfarcts, which is shown in figure 2D. In the immunofluorescence imaging, these two figures actually show deposition of immune complexes. In first figure, it's C1q positivity, and in the second figure, it's IgG deposition in a similar caliber arteriole. So we talked about SLE. SLE is actually one component of lupus spectrum disorders. There's a wide heterogeneity in lupus spectrum. You have SLE, then you have childhood SLE, which is onset less than 18 years of age. You have incomplete LE, you have nephritis, you have cutaneous lupus, which only affects the skin. And then you have mixed connective disorder, which has distinct elements outside of usual lupus spectrum, such as erosive arthritis. And you also have antiphospholipid syndrome, which may exist as a separate entity, but may be a part of SLE. It is one of the other most common disorders in the lupus spectrum that can have neurological manifestations. So apart from SLE, APS syndrome is also very commonly involved in causing CNS issues. So what is APS? It's an immune-mediated disorder, antibodies directed against phospholipid binding proteins. Most common manifestation is acute ischemic stroke, followed by TIA, cerebrovenous thrombosis, and less frequently Sneddon syndrome and RCVS. Lupus antigen is the best predictor risk of any venous or arterial thrombosis. You have a clinical criteria of vascular thrombosis and pregnancy morbidity. And you also have a lab criteria which should be positive on 2 or more occasions, at least 12 weeks apart. So 3 antigens: lupus anticoagulant, anticardiolipin antibody, and anti-beta-2 glycoprotein antibody. The pathogenesis of antiphospholipid syndrome is actually most widely accepted is the 2-hit hypothesis, but the other pathogenesis are abnormal coagulation function and vascular endothelial injury, arterial thrombosis by upregulating the plasma levels of active von Willebrand factor and by promoting platelet activation, immune-mediated vascular inflammatory or direct neuronal effects. Overall, antiphospholipid antibodies are actually present in 1 to 5% of general population, with higher prevalence in older subset. However, it is not all of the patients with antiphospholipid antibodies go on to develop antiphospholipid antibody syndrome. So the prevalence of that is lower. This slide just kind of shows the main neurological manifestations overall that could be seen in antiphospholipid antibody syndrome. So you have ischemic stroke and TIA. Ischemic stroke is seen in about 20%, TIA in 11% of patients. You have cerebral venous sinus thrombosis in 0.7%, seizures and epilepsy in 6 to 9%, neuropsychiatric symptoms in 40 to 80% of patients, so very common. Headache, migraine with and without aura is seen in 20%. And then the other manifestations are chorea and other movement disorders and inflammatory disorders, including NMO-like diseases and transverse myelitis. And then also PNS manifestations such as carpal tunnel syndrome, polyneuropathy, mononeuritis multiplex. Sneddon syndrome is actually a slowly progressive non-inflammatory thrombotic vasculopathy that can also be seen in antiphospholipid syndrome, characterized by livedo reticularis and recurrent cerebrovascular, hemorrhagic, or ischemic events. So Now talking in a little bit detail about some of the CNS complications that I briefly touched upon. So first is stroke. So in lupus patients, SLE has actually been found to be an independent risk factor for stroke. The stroke in lupus patients is more severe and more extensive. Some of the risk factors are younger age, male sex, hypertension, hyperlipidemia, smoking, which are traditional stroke risk factors, elevated homocysteine level, African descent, use of steroids, and presence of antiphospholipid antibodies on top of SLE actually also increases stroke risk. While use of hydroxychloroquine has actually been shown in some studies to be protective against ischemic stroke. The incidence of ischemic stroke is in about 3 to 20% of SLE patients, more common in first 5 years after diagnosis. There was this one study where they compared SLE versus non-SLE patients, and 90% of SLE patients had ischemic stroke versus 63% in non-SLE patients, but this was a very small study. Ischemic stroke, as I mentioned, are likely to be more extensive and more severe, and the most common imaging pattern observed is either multiple infarcts or border zone infarcts. It has been shown that 30-day mortality in SLE patients was slightly higher, but the difference is actually very obvious when you check the long-term mortality of 8 or more than 8 years of follow-up, during which 15% of SLE patients passed away as compared to 3% of ischemic stroke patients who did not have SLE. Some of the pathophysiological mechanisms, as touched briefly in the prior slides, were thromboembolic disease, accelerated atherosclerosis, vascular inflammation, and or hypercoagulable state that can lead to ischemic stroke. This slide actually shows the forest plots of pooled risk ratios for stroke patients in SLE compared with general population or healthy control. It's a meta-analysis of several studies. It shows that increased risk of ischemic stroke in patients with lupus with pooled relative risk of 2.818% and also increased risk of intracerebral hemorrhage with relative risk of 1.84%. However, this study also looked at risk of subarachnoid hemorrhage, didn't add that diagram, but that did not differ significantly between patients who did have lupus and patients who did not have lupus. The RR number was 1.95%. The 95% confidence interval for subarachnoid hemorrhage actually ranged from 0.69 to 5.52. So it was not statistically different. This table shows clinical outcome of stroke in SLE patients. At 90 days post-stroke, the mean modified ranking scale score was significantly higher in SLE patients as compared to controls. And the proportion of functional dependence, MRS score of 3 to 6, was also higher in SLE patients. It was 32% versus 8.3%. There was also higher risk of stroke recurrence. So SLE patients, not only did they have more severe strokes, were more dependent at the time of discharge, but they also had higher rate of stroke recurrence. And there was also a non-significantly higher 30% post-stroke mortality that was observed in SLE group. The slide also shows some of the complications. So you have that can be seen within 30 days. You have epilepsy, which was more common in SLE versus non-SLE patients. And then the other complications were not different. It was aspiration or use of feeding tube. Now going on to stroke in patients just with antiphospholipid antibody syndrome. Presence of antiphospholipid antibodies actually causes a 5-fold increase in stroke in patients under 50 years of age. So these are both diseases that cause stroke in young. This diagram actually shows temporality of stroke subtypes with diagnosis of antiphospholipid antibody syndrome. The timing from APS diagnosis to stroke onset is highly variable. You can see that most intracranial hemorrhages, they occurred more than 4 years after diagnosis. There's a huge jump right here in intracranial hemorrhages at 4 to 9 years. Early on, there's prior is cerebrovenous sinus thrombosis, and then you see ischemic stroke is kind of almost the same, but there's the big jump in intracerebral hemorrhage. And this is despite low frequency of anticoagulation related hemorrhage. So just being on anticoagulation would not explain this big jump. As I said, ischemic stroke occurred early in 45% of cases before or at the time of APS diagnosis, but it can occur late too. And the early recurrence of cerebrovenous sinus thrombosis in about 63% cases actually suggests that venous sinus thrombosis may be the first manifestation of antiphospholipid antibody syndrome, which is something to keep in mind. So this was actually an abstract that we presented at International Stroke Conference in 2021. So this was a retrospective survey of neurovascular complications in lupus spectrum disorders in patients within Kentucky, Appalachia over a 5-year time frame. Female to male ratio was 4:1, showing female female increased number of females, and the median age was 48 years. Ranged anywhere from 22 to 87. Most common lupus spectrum disorder that we saw was SLE and or antiphospholipid syndrome. Frequency of ischemic stroke was 56%, with most of the patients having multifocal infarcts, and then some had isolated cortical strokes, and 7 patients actually had lacunar infarcts in subcortical structures or brainstem. Outcomes in our study actually, contradictory to the prior data. 64% patients actually did well and were ultimately discharged home, but 25% were readmitted with recurrent strokes throughout the year. We also saw other complications. 5% patients had lupus vasculitis. 4% had moyamoya syndrome. ICH was seen in 5.3%. And venous sinus thrombosis was seen in about 2.7% patients. So we talked about stroke in lupus spectrum disorders. There are multiple mechanisms, as we touched, of causing stroke. What about lupus vasculitis? I feel like we talk about this a lot because a lot of patients with lupus spectrum disorders can have, when you do CTA, they can have accelerated atherosclerosis, which, or they can have an actual vasculitis affecting the vessels, which can both lead to similar appearance on imaging, just kind of showing like segmental stenosis or dilatation, or more commonly known as beading appearance of the vessels. So lupus vasculitis, it's actually overall just vasculitis in general. The prevalence is 11 to 35%, but most commonly it involves the skin. Predominantly involves small vessels, but medium-sized vessels can also be affected. However, for lupus vasculitis to affect large arteries, it's very rare. CNS vasculitis is about 1 to 10% from the lupus vasculitis cases. The diagnosis is made by, along with the normal workup, you need to do CSF testing, you need to do conventional angiography, which will show segmental stenosis and dilation in multiple vascular territories, but the gold standard is brain biopsy. The other manifestation that can happen in patients with SLE, another CNS manifestation, is progressive multifocal leukoencephalopathy. It is a rare RPML. It's a rare complication. Incidence is about 1 to 2.4 cases in 100,000 person years. The mechanism and risk of PRES in SLE patients are poorly understood, and it is an area of active research because you can have PML just by the virtue of being on immunosuppression, but you can also have PML from lupus. So that actually confounds treatment a lot, because should you or should you not continue immunosuppression in those patients? This is a serial MRI brain scan in a 40-year-old woman with SLE. She received 10 infusions of belimumab, a monoclonal antibody which inhibits B lymphocyte maturation, over 1 year. And then you see the coronal T2 FLAIR images show patchy T2 hyperintensity in the subcortical white matter of both hemispheres after conclusion of belimumab treatment. Rapid progression is shown in a repeat MRI obtained 3 months later. So you see subcortical vasogenic edema concerning for PML. You have other complications, which are cerebral atrophy and myelitis. So about 32 to 71% of patients with SLE can cause significantly more common. It is significantly more common in patients that receive long-term corticosteroids than in healthy matched control. Atrophy can happen by the virtue of the disease itself and also by being on steroids. That's why long-term high-dose steroids are not usually recommended in these patients. About 1.2% of patients in a large case series had myelitis, which can cause significant neurological deficits. So this slide kind of shows some of the investigations that we get for patients with neuropsychiatric SLE or lupus spectrum disorders. You get, along with general labs such as CBC, CMP, LFTs, UA, you get complement levels, you get ANA, anti-dsDNA, antiphospholipid antibodies, lupus anticoagulant, you do a complete thrombophilia screen, cryoglobulins, CSF examination, MRI brain and or spine with gadolinium, EEG, along with other tests when indicated, such as echocardiogram, MR angiography, catheter angiography, SPECT, PET scan. This slide shows the treatment of medications used generally in treatment of SLE in the table, but the treatment of neuropsychiatric SLE, it's usually high-dose IV steroids such as methylprednisolone and additional immunosuppressants. Among immunosuppressants, IV cyclophosphamide has the most evidence. However, its efficacy should be weighed against its significant toxicity. Rituximab has been used in success in some cases. Treatment of antiphospholipid antibody syndrome, primary thromboprophylaxis in APL positive individuals is aspirin. And but if you have antiphospholipid antibody syndrome, then vitamin K antagonists. Studies have shown that patients in which we use DOACs, they can actually have recurrent thrombotic events. So use of DOACs is not recommended. I think we only have about 10 minutes, but so I'm gonna quickly jump on to rheumatoid arthritis. So this was a case that kind of shows a woman who presents with 3-month history of frequent episodes of speech disturbance, confusion, and right-sided weakness. She carries a diagnosis of rheumatoid arthritis. This was the MRI that was obtained for her, which showed non-contrast FLAIR MRI, and then a contrast weighted scan, which shows abnormal FLAIR hyperintensity and contrast enhancement in the meningeal region on the left side. She actually finally underwent brain biopsy, which showed lymphoplasmacytic inflammation with multinucleated giant cell. Biopsy of dura mater in slide B showed pachymeningitis. And then the biopsy of the pia mater showed classic rheumatoid nodule with caseating granuloma and a necrotic center surrounded by inflammatory cells. So she was diagnosed with rheumatoid meningitis. Rheumatoid arthritis is a chronic autoimmune disease. It can lead to CNS involvement due to 3 etiologies. Diseases directly related to RA, which includes the rheumatoid meningitis, but diseases not related to RA. There is higher risk of cerebrovascular events in these patients, including stroke, and then the diseases related to the use of anti-TNF drugs. This slide kind of shows, it's a very busy one, but it shows what are the common characteristic patterns of neurologic involvement in autoimmune diseases. So we talked about lupus, we talked about rheumatoid arthritis, but there's also Sjogren's syndrome, which can cause aseptic meningitis, seizures, not stroke, but can cause a lot of PNS manifestations. You have systemic vasculitis, and the increased risk of stroke is seen in them, including Takayasu's arteritis and polyarteritis nodosa, along with scleroderma, psoriatic arthritis, and ankylosing spondylitis, which can cause neurologic involvement. Conclusions, CNS manifestations of autoimmune diseases are important to recognize, as they may often be the presenting manifestations and can be associated with increased morbidity and other complications. Timely diagnosis, often requiring multidisciplinary care, is essential to minimize morbidity and decrease risk of permanent neurologic deficits. Thank you.
Dr. Grewal, thank you very much. That was an excellent talk and excellent topic, because there's always, so many people with autoimmune diseases in the hospital, and sometimes it's like, are these related or not related? And sometimes, does that change the treatment? Because I think that's from the practical perspective, does that really, change the treatment? And when do you make a decision, to switch, somebody who has the stroke and has history of autoimmune disease, does that warrant switching to the stronger immunosuppressive medication? So I guess that would be the first question. Just seeing the patient in the hospital, somebody came in with a stroke, a 60-year-old person with history of lupus, does that warrant change in the lupus treatment?
Well, it depends on what you think the stroke etiology is and what is the location of the stroke. If the patient has, if the lupus is well controlled, if the autoimmune lab panel is within normal limits, the treatment is going on well for several years, obviously I would recommend consulting the rheumatology colleagues if they say the lupus is well controlled and she hasn't had a flare up, and the patient had other risk factors for having stroke, such as it's a small vessel location and the patient has elevated LDL, diabetes, blood pressure, and other issues, then probably not. But if you don't have other traditional risk factors, the lupus is not well controlled, she has other other systemic manifestations of lupus flare, including renal involvement or skin involvement, and then you do stroke workup, you see some irregularities in the vessels, might consider doing LP, and at that point, yes. So it would involve multidisciplinary care and close relationship with the rheumatology colleagues.
Now, I believe you mentioned that during the talk, but what is a preferred treatment if somebody is diagnosed with a lupus vasculitis?
Lupus vasculitis, if it affects CNS?
Yes.
Okay. So the preferred treatment at that point would be high dose pulse steroids, IV methylprednisolone, and then along with immunosuppressive regimen. Most commonly, we have the most evidence for cyclophosphamide, but in some anecdotal cases, rituximab has been used.
Okay. Now, when your talk is a little bit more about the systemic diseases and CNS manifestation, but isolated CNS vasculitis, is there any difference in management of that, and what is this the similar mechanism as a systemic vasculitis? What can you comment on that?
Yes, I think just one second. Yes, I think the mechanism is same. It's just that the cutaneous vasculitis is way more common. CNS vasculitis, even though I feel like we talk about it a lot, but it is very rare. And the diagnosis, the gold standard is a biopsy, because you can have accelerated atherosclerosis in lupus patients due to immune complex and other inflammatory cascade that happens, and on CTA and even on conventional angiography that might look almost the same.
Okay. Now, how to differentiate somebody who has lupus and presents with a stroke? How to differentiate whether the stroke is because the patient has vasculitis or vasculopathy secondary to immune complex deposition, or one of the different other mechanisms?
The only way to really differentiate is to get a biopsy. I mean, that is the gold standard, the biopsy. And even a lot of the time, the biopsy might not, depending on where you get the sample from, it might, or if you started steroids before, the biopsy might come back as negative. I think in those cases, if you do have high clinical suspicion of actually the patient having lupus vasculitis, I think you should err on the side of actually treating the patient as a lupus vasculitis.
You mentioned the PML in lupus. Is
Yes.
but the PML also related to the JC virus infection related PML?
It can be, because these patients are on immunosuppression, but the mechanism of PML in lupus is not really clearly understood. It is thought that lupus itself can cause PML by just like chronic inflammation and with having JC virus in it. Patient being co-infected with JC virus, but also because the patient is on immunosuppression, that is another thing that it can cause PML.
Okay. And is the management also similar as it would be in other conditions, stop immunosuppressive, and is that correct?
I think at that point, you do need to switch immunosuppressives to kind of see if there's, if by switching immunosuppression, going on to stronger immunosuppression would actually help.
Okay. What is the mechanism of the stroke in rheumatoid arthritis? In a sense, is it like vasculative, vasculopathy, thrombotic, all of it, possible, everything?
Yes, so it is due to chronic inflammation. So chronically, rheumatoid arthritis, it's a chronic autoimmune disease. There's chronic inflammation, so that can lead to stroke. But also, you can have stroke due to aseptic meningitis. So you have aseptic meningitis from rheumatoid arthritis, and that can lead to stroke.
Dr. Grewal, thank you very much for your talk. It was excellent talk. I actually just got a comment. Fascinating and useful lecture. Thank you from one of the audiences. Thank you very much, everybody. Have a good day.
Thank you. Thank you, Peter.